Good morning, one and all. Today we shall discuss about the pathophysiology of GI tract. We shall be discussing today about some of the common problems and common diseases which are seen in the population which are related to the gastrointestinal tract. A small study or data in the Americans suggests that the digestive diseases and the diseases related to GIT are taking the proportion of a pandemic. In fact, it is said that about 70 to 95 million Americans are affected every day, for which about more than 10 million people or patients are hospitalized every year. Among the various diseases, one of the most severe diseases and the fatal diseases are the colorectal cancer, which is taking the proportion of the second deadliest cancers in the USA. And the third leading cause for most of the GIT related diseases is the diarrhea. Now let us see what are the basic common GI problems. One of the commonest diseases related to the GIT pathophysiology is the GERD, G-E-R-D. The full form of this GERD is Gastroesophageal reflux disease. We'll discuss about this little later. The other common diseases are the ulcers, the colorectal cancers, gallstones. Gallstones are nothing but stones present in the gallbladder, multiple stone, or it can be a single solitary stone, or the stone, instead of being in the gallbladder, can also be formed and got stuck in the common bile duct or along the tract of the common bile duct. Then viral liver diseases, where there is inflammation of the liver functions getting affected, rectal complaints, and constipation. The other common GI problems, but to a lesser extent, is the regular and the misuse of alcohol, which results in ultimately the liver getting damaged, resulting in alcoholic liver diseases, hemochromatosis, where there is an accumulation of iron, inflammatory bowel disease, irritable bowel syndrome, food intolerance, intestinal gas problems, and abdominal pain. Now let us discuss first of all xerostomia. Xerostomia means a dry mouth. One of the commonest cause and complaints of this xerostomia dryness would be drug related. Some of the drugs are known to cause dryness in the oral cavity. The patient complains of dryness of the mouth, difficulty in swallowing because of the dryness in the oral cavity. This is because of there can be certain insufficient capillary perfusion, or it can be autoimmune diseases, or some radiation treatment are being given for treatment of certain cancers. So this radiation treatment or radiotherapy may result in xerostomia. The other is the drooling. The drooling is nothing but salivation or saliva trickling from the mouth, or excessive formation of saliva because of the excessive secretion of salivary glands. This is because of certain overactive salivary secretions. The treatment for this would be giving anticholinergic drugs or certain surgical removal of the minor salivary glands, as a result of which the amount of saliva secretions can be reduced. Then let us see some of the disorders of swallowing. Now, what is the disorder of swallowing? Now, the disorders of the swallowing or inability to swallow can be to a mild extent or to a major extent. Major inability to swallow is complete loss of the ability to swallow. The swallowing reflex or the deglutition reflex is lost. As a result of which, when there is a complete loss of the swallowing reflex, the patient is unable to swallow. There can be other conditions also where there is a weakness of the swallowing of the muscles which are involved in deglutition. The swallowing reflex is partially affected, as a result of which what happens, whenever there is a weakness in the swallowing reflex, the food, instead of going into the esophagus, because of the improper closure of glottis, goes into the lungs. Or whenever there is a weakness of the swallowing reflex, the posterior nares do not descend down and close the posterior pharyngeal wall, as a result of which the food may sometimes drool or enter into the nasal cavity. So there are these three different problems. These are three different pathophysiology associated with the swallowing reflex. Either there should be a complete loss of the swallowing reflex, or there should be a weakness in the swallowing reflex, where because of the failure of the closure of the glottis, instead of the food going into the esophagus, enters into the respiratory tract, or improper closure of the posterior pharyngeal wall results in the food getting refluxed into the nasal cavity. Now, what are some of the commonest causes for this dysphagia or the disorders of the swallowing? One, cerebrovascular accident, which is known as stroke, is one of the commonest cause for this difficulty in swallowing or dysphagia. Or isolated or combined damage to the 5th, 9th and the 10th cranial nerves will result in dysphagia. The complication of this disorder or the CVA is, if the person tries to swallow, it will result in aspiration. Aspiration results in the contents going from, instead of into the esophagus, into the respiratory tract. There can be another problem where this reflux, where the small quantities of the gastric secretions, when they regurgitate, instead of getting swallowed, will enter into the respiratory tract, trachea and the lungs, and will result in aspiration pneumonia or aspiration pneumonia. There can also be a dysphagia because of certain muscular diseases like polio, where there is a weakness of the motor muscles, or myasthenia gravis, where the neuromuscular junction is affected, or the botulism, where the botulinum toxin is secreted, and this secretion of this toxin will result in paralysis of the muscles of swallowing. The other common condition where you find that there is an aspiration or temporary cessation of swallowing reflex or dysphagia is deep anesthesia. In general anesthesia, normally the swallowing reflex is gone. As long as the anesthesia person is under anesthesia, the swallowing reflex is inhibited, as a result of which there can be a possibility that the contents of the stomach get aspirated into the lungs, resulting in aspiration and hypoxia. This is one of the commonest complications which happens when a deep general anesthesia is given. To prevent this complication, it is generally advised that before general anesthesia, 12 hours the patient should be fasting, so that there is no gas, there is no content, the stomach is empty, and our chances of aspiration are reduced. Another cause of this, another disease which is affecting the GI tract is called as Achalasia and megaesophagus. Now, what do we mean by Achalasia? Normally, after deglutition, the food enters into the esophagus. As it travels along the full length of the esophagus, in the lower two-thirds of the esophagus, there is a sphincter which is known as the lower esophageal sphincter. In anticipation of the food entering into the esophagus, there is an opening up of the lower esophageal sphincter. If there is a failure of this esophageal sphincter to relax when food is present in the lower two-thirds of the esophagus, the esophageal sphincter remains tightly constricted, does not relax, thus preventing the entry of the food into the stomach. That is, the receptive relaxation does not take place. As a result of which, what happens is the food gets accumulated in the lower end of the esophagus, and that becomes the storehouse of the food. Slowly, over a period of time, if this problem is left untreated or uncorrected, the esophagus enlarges in size and becomes the size of nearly half or one third of the size of the stomach. That is called as a mega esophagus. This mega esophagus can hold at least 1 liter of food. What is the cause of this problem? The cause of the problem is there is a motility disorder affecting the lower third of the esophagus, where the lower esophageal sphincter fails to relax, as a result of which the lower esophageal pressure is high. The peristaltic contractions are absent. There is a dysfunction of the myenteric plexus. We know that the whole of the GIT is supplied by autonomic nerves, and this includes the mesenteric plexus and the myenteric plexus. So the myenteric plexus is responsible for causing up of the opening up of the lower esophageal sphincter. Dysfunction of this plexus will result in the tight constriction of the LES, inability to open, the food getting accumulated in the lower end of the esophagus, and over a period of time it results in a mega esophagus. Ultimately, the complication further, if left untreated, may result initially in the ulcerations of this esophagus. Subsequently, the esophagus may get ruptured and untimely death can happen. Now, what are the symptoms which a patient will complain when he is suffering with achalasia cardia and megaesophagus? First, there will be a difficulty in swallowing liquids as well as solids. The more is for solids, less for liquids. Quite often there will be regurgitation of the undigested food. Because the food is not entering into the stomach, there is no breakdown of the proteins, fats, carbohydrates, no absorption of the food, no absorption of the nutrients present in the food. It will result in weight loss, halitosis, blenching and heartburn. Now, what is the treatment for this achalasia cardia and megaesophagus? First, either there is a antispasmodic drugs are given. These drugs will help in relaxing the smooth muscles so that the tone of the lower esophageal sphincter is reduced. It relaxes whenever there is a food received in the lower end of the esophagus. The other would be to dilate the lower end of the esophagus, so that it is called as a pneumatic dilator, so that a passage is created so that food can enter from the esophagus into the stomach. The other line of treatment would be a surgical myotomy, where surgery is done, and in that surgery the sphincter is the smooth muscles of the sphincter are cut and it is removed. Now let us see some of the common problems of gastric motility. One of the commonest disorder concerned with gastric emptying is the slow gastric emptying. Normally, when food enters into the stomach, it remains in the stomach for some time, and the gastric emptying time is around 2 to 3 hours. In some patients, this gastric emptying becomes very slow and food gets retained within the stomach for a longer period of time. Ultimately, when the stomach doesn't get emptied and the food continues to remain in the stomach for a time beyond 3 to 4 hours, the patient will complain of fullness of the stomach for most of the time. So for 10 to 12 hours from the previous meal, the patient will still not have any hunger sensation of hunger. Hunger contractions will not be in the stomach because the stomach doesn't get emptied. The first common complaint would be that there is a fullness of the stomach after taking food for a long time, or the fullness of the stomach after eating very little quantity of the food. Also, simultaneously, because the nutrients or the food is still present in the stomach, there will be loss of appetite over a period of time. There can be complaints of a vomiting sensation, and in fact vomitings can also happen. Now, what are the causes for this slow gastric emptying? One of the commonest causes of this slow gastric emptying is healed gastric ulcer. Obstruction, physical obstruction to the movement of the stomach, movement of the food from the stomach into the small intestine, and this obstruction can be in the form of certain growth which is present. It can be a benign tumor, malignant tumor, or can be a polyp, that is a cancer. Rare causes are scleroderma, eating disorders, especially anxiety related disorders, depression or obesity, and sometimes it can be because of the dysfunctional autonomic nervous system, that is the myenteric plexus and the Mesenteric plexus. The treatment is pyloroplasty or balloon dilatation. Balloon dilatation is insert a balloon, expand the stomach so that the emptying can take place. Pyloroplasty is reducing the tone of the pyloric sphincter so that the food or the chyme enters from the stomach into the duodenum. This slow movement of the stomach is also called as gastroparesis. What does gastroparesis means? Gastroparesis is partial paralysis of the stomach or slow emptying of the stomach. This gastroparesis is commonly seen in diabetics, and among the diabetics it is most commonly seen in the type 1 diabetes, that is insulin dependent diabetes. It is also seen in non-insulin dependent diabetes or type 2 diabetes, but here for type 2 diabetics to get gastroparesis, the diabetes should be prevalent for a longer period of time. In other words, gastroparesis can be seen early in type 1 diabetics, little later in type 2 diabetes. The cause of this gastroparesis in diabetes is the uncontrolled diabetes causing damage to the vagus nerve. The symptoms, same. There will be early feeling of fullness when eating, that is within when the person has already taken a little quantity of food, the person completes that he has done, he is full and he cannot eat anything more. So early feeling of fullness, the stomach remaining full for a long period of time. Weight loss can be one of the symptom complaint. There can be a bloating sensation or a little abdominal discomfort. Added to it, they may also be seen with complaints of nausea and vomiting. The only treatment for this is gastroparesis is to have a tight control over the blood glucose levels, so that there is no onset of the disease itself. Now once it is there, you can treat this condition by giving some prokinetic drugs, where these prokinetic drugs initiate the gastric motility so that the gastric movements start early, the emptying time is reduced so that the patient gets relieved of his fullness and abdominal distension. Then there can be a rapid gastric emptying. This rapid gastric emptying is nothing but something like a diarrhea, where as soon as you take a food, you find that there is a sudden severe stomach contractions resulting in a very rapid emptying of the stomach. It is commonly seen in diarrhea, where there is an increased osmotic load. This stimulates the smooth muscles of the stomach. Stimulating the smooth muscles of the stomach will result in excessive gastric contractions, and the food gets emptied from the stomach into the small intestine rapidly. Ultimately, results in diarrhea. Hypotension can be a cause because of the decreased extracellular fluid volume. Insulin surge from a rapid sugar load, that is reactive hypoglycemia. Rapid sugar load in the sense you know that there is a sudden spurt in the insulin secretion within minutes after taking food. So that insulin surge can also cause rapid gastric emptying. Duodenal ulcer, where the acid erodes the mucosa, can also cause increased gastric emptying. Now the other common condition which is seen is the gastroesophageal reflux disorder. Smallly called, it is in short called as GERD, GERD. As the name would suggest, GERD means gastroesophageal reflux disease. What does this mean? The word itself is self-explanatory. There is a reflux of contents from the stomach into the esophagus. Normally, after the deglutition reflex is done, there is a relaxation of the lower esophageal sphincter. The sphincter opens up, the food enters into the stomach, and after that, the lower esophageal sphincter remains tightly closed. In some conditions, there is a incomplete closure of this LES, as a result of which the contents from the stomach regurgitate back into the esophagus. Now, when there is a regurgitation of these contents back into the esophagus from the stomach, it would result in the damage to the lower two-thirds of the esophagus, because the gastric contents are rich in hydrogen ions and acid pepsin. This results in the patient often complaining of indigestion and heartburn. Commonly, this GERD is predominant when the person is in lying down position. So if a person who is suffering with GERD after a meal goes back to the bed and lies down on the bed, there is an increased probability of the gastric contents regurgitating into the esophagus, as a result of which the person will start experiencing retrosternal burning sensation, which is also called as heartburn and indigestion. If this remains untreated for a long period of time, it can result in a stricture of the esophagus, which is nothing but a fibrosis of the lower end of the esophagus, or it can also get aspirated into the lungs and result in an asthma aspiration, or it can get reflux into the throat repeatedly, resulting in chronic sinus infection, and rarely it leads to Barrett's esophagus. So ultimately then, what is the treatment for this? The treatment for this is, since the food is getting regurgitated into the esophagus, one of the treatments suggested is the patient should have multiple meals, should eat multiple times in small quantities. Second line of treatment, the second treatment would be that the person should sleep in a reclining position where the head end of this patient is little 45 degrees higher than the rest of the body. That is, in a tilted position where the head end is at a higher end by about 45 degrees and the rest of the body is inclined lower down. This will prevent the reflux of the contents from the stomach into the esophagus. Thirdly, to avoid any activity doing on bending positions where there is an increased chance of regurgitation. These are the non-pharmacological treatments where simple measures of this will give a relief to the patient to a greater extent. If still the regurgitation is persisting, some prokinetic drugs can be given so that the gastric emptying occurs faster, retention of food in the stomach doesn't remain for a longer period of time. One more non-pharmacological treatment would be to advise the patients not to go on to the bed immediately after eating the food, or at least 3 to 4 hours later. Then the other common cause is peptic ulcers. What is peptic ulcers? We know that food in the stomach causes gastric secretions which are rich in hydrogen ions and pepsin. The gastric mucosa is lined, this gastric wall or the stomach wall is lined by a gastric mucosa formed by the secretion of mucin, and this mucin is a protective covering which prevents the movement of the hydrogen ions through the mucosal barrier into the inner layers of the gastric wall, thus protecting the smooth muscles from damage of the pepsin and the hydrogen ions. Now, when this barrier is broken, it may result in ulcers, and such ulcers are called as peptic ulcers because this occurs when the effect of acid and pepsin is seen into the inner layers of the stomach wall after the barrier is breached. In other words, in simple words, the mucosa is unable to protect the inner layers of the stomach. If the ulcer is in the stomach, it is called as a gastric ulcer. If it is in the duodenum, it is because it is called as duodenal ulcers. The cause for the gastric ulcers and the duodenal ulcers are different. If an ulcer happens in the stomach, it is because of the decreased ability of the mucosa to protect itself. That is, the gastric mucosa is not able to protect itself, or there is a less secretion of the mucin in the mucosal layer. If the ulcer is in the duodenum, the cause is different because here there is a exposure of the duodenal mucosa to increased amount of hydrogen ions, that is acid and pepsin. Just to recap, what is gastric mucosal barrier? The gastric mucosa is lining the stomach wall. It has got a physiological and anatomical basis to prevent the back leak of hydrogen ions. What is this anatomical barrier? The anatomical barrier are nothing but the cell membranes and the tight junctions which are present between the cells. Cell membrane does not allow the leak of the hydrogen ions. In addition to this, the adjacent cells are having tight junctions, thus it acts as a physical barrier or an anatomical barrier. What is the physiological barrier? The physiological barrier is nothing but where the diffused hydrogen ions are transported back into the lumen so that the hydrogen ions do not enter into the gastric wall. Now, what weakens and what strengthens the integrity of the mucosal barrier? The weakness of the mucosal barrier is compromised when there is a bacterial infection. There is an infection of the gastric mucosa, and the most commonest bacteria which has been isolated is the Helicobacter pylori, which is one of the causes for the ulcer formation of peptic ulcers. Then, excess consumption of ethanol can damage the mucosal barrier. Excess consumption of drugs like aspirin or your non-steroidal anti-inflammatory drugs, that is painkillers, can also cause damage to the mucosal barrier, plus bile salts. Once this barrier is damaged, it results in inflammation of this gastric mucosa and ultimately in ulcers. Now, what are the factors which keep this integrity of the mucosa healthy? One is good secretion of mucin from the gastric mucosa, bicarbonate ion secretion, gastric ions, gastrin secretions, and the epidermal growth factor. So both these things are responsible for a healthy mucosal barrier. This healthy mucosal barrier can prevent the damage because of the excess consumption of drugs like aspirin or the non-steroidal anti-inflammatory drugs. So there has to be balance maintained between factors which are causing a healthy mucosal barrier and factors which are causing damage to this mucosal barrier. Now, what does this happen? What damage does happen to the body when there is a damage here? The hydrogen ion back leaks into the mucosa in exchange of sodium ions. This is the basic pathophysiological changes which are happening before it forms a gastric ulcer. The decreased pH in the cell leads to cell death. The damaged mast cells, that is the enterochromatophin cells, will cause an increased leak of histamine. This histamine will cause more vascular damage, it will cause more local damage to the cell wall, more leakage of hydrogen ion, and more formation of ulcers. Helicobacter, as I said earlier, Helicobacter pylori is one of the bacteria which is implicated in the duodenal ulcers. What is the treatment for peptic ulcers? First of all, the treatment of peptic ulcer is to give antacids. When these antacids are given, they damage the hydrogen ions, as a result of which the effect of the hydrogen ions are neutralized. Then the other thing would be, the next line of drug is to give the H2 receptor blockers. These H2 receptor blockers are nothing but histamine receptor blockers which are present over the cells, and this histamine is secreted by the ECL cells which are present in the gastric mucosa. If these drugs like ranitidine and cimetidine are given, they will block the H2 receptors. If these H2 blockers are given, they will prevent the release of histamine and prevent the release of gastrin. Then finally, if these two drugs are not working, the other thing is the proton pump inhibitor. Drugs like omeprazole, pantoprazole are given, where these will block the proton pump. So blocking of this proton pump will prevent the release of the hydrogen ions into the cell lumen. Now the other condition going down, there is a pancreatic diseases of the pancreas. The disease of the pancreas, one of the commonest causes is pancreatitis. Pancreatitis is inflammation of the pancreas. There can be a acute pancreatitis or there can be a chronic pancreatitis. Acute pancreatitis is sudden inflammation of the cells of the pancreas. Chronic pancreatitis is if this inflammation to a slower extent or to a lesser extent persists for a long period of time, it is known as chronic pancreatitis. The other rare cause of the disease of the pancreas could be the malignancy or cancer of the head of the pancreas. Now pancreatitis means inflammation of the pancreas. We know that there are the ductal cells and the acinar cells. The ductal cells will secrete bicarbonate ions. The acinar cells will secrete the enzymes responsible for the digestion of carbohydrates, fats and proteins. Whenever there is an inflammation of these acinar cells, the inflammation will cause the release of these enzymes. Release of these enzymes will cause the enzymes to get activated, and these enzymes get activated within the pancreas itself, whereas they have to get activated within the duodenum. So once the pancreas starts activating these enzymes within itself, it can digest the proteins and carbohydrates. The whole of the gland is nothing but made of protein. They start dissolving or digesting the protein itself. Ultimately the pancreas gets damaged. The other condition which is seen lower down in the small intestine and large intestine is malabsorption. Malabsorption means failure of absorption of fats, specifically malabsorption for fat, because fat can easily be measured in stool unlike carbohydrates or proteins. Motility disorders can cause malabsorption. Failure of the nutrients to get absorbed into the GI tract could be because the contents moving very fast through the length of the intestine, as a result of which it cannot get absorbed. Digestion disorder, where there is not enough digested of the carbohydrates, proteins and fats are not completely digested to get absorbed, as a result of which there is no absorption, commonly seen in pancreatitis. Or it can be sprue, which can be a tropical sprue and a non-tropical sprue. This can be because of infections. The other commonest cause is diarrhea. Diarrhea is the third leading cause of death in the world. Most of the time diarrhea is affecting children. It is caused because of increased secretion within the small intestine, or it can be because of increased motility or increased movements of the small intestine or the large intestine. Normally the diarrhea is infectious in nature. Commonly it is infectious. The infection may be because of either a virus, viral diarrhea, or bacterial cholera, bacterial diarrhea, or a protozoal infections. Rarely the cause can be ulcerative colitis or drug related. To a mild extent, there can be a psychogenic diarrhea where impaired psychological status is causing diarrhea. Other causes which you should just know at this stage is diverticulitis and a colon motility disorders. Thank you one and all. Have a good day.